Hello. Today we will be going over my presentation called Play the Cards You're Dealt. My name is Zach Winkleman. I am a PhD student in curriculum instruction in the athletic training education concentration. This is a project intended for the Doctorate in Athletic Training program as a portion of my degree. Today we are going to look at the disablement model and health-related quality of life, injury prevention risk factors, in terms of what this looks like for clinical integration. So to do so, I have created a mock patient for us to kind of take it through of what this would actually look like for clinical integration. So our patient is an 18-year-old female collegiate cross-country member, and now we'll take her across the continuum of the disablement model. The first part of the disablement model is origin. So the origin of her disease is medial tibial stress syndrome, also known as shin splints in the literature. This is defined as exercise-induced localized pain along the distal two-thirds of the posterior medial tibia. While the pathophysiology is often debated about what the actual root of the disease is, the definition is kind of broad. So this can include things in definitions such as shin splints and medial tibial syndrome itself, not a stress. So you may see this defined in the literature as something that is often in exercise or active individuals such as military and runners, but typically along the distal two-thirds of the tibia is where the pain is located. So for our patient, the patient then would report on the disablement model as an organ. For herself, this would be increased shin pain. So using the numeric rating scale or visual analog scale, she could increase or dictate what the pain would be. There's also potential for decreased strength and decreased range of motion in this area. So this would be something where, as a result of pain, she would have decreased strength or decreased range of motion into the lower extremity. Next on the disablement model is the person. This part of the disablement model actually looks into what is important to that individual. For this individual, it'd be the inability to run more than 5 miles at one time. In cross country, this runner may experience running 7 to 10 miles per day as part of her training load. The pain may onset at 5 miles, and this is her, as a person, her disablement. There's also a disability present on the left's an MTSS score. Using these patient-reported outcomes lets you integrate what the patient's reporting in terms of functional limitations, but also at the organ level, but also on the personal level. The MTSS score is a patient-reported outcome measure that has constructs into pain and activity during activity in terms of what their sport activities of daily living, and outside that at rest. Next is societal limitations. The societal limitations for this patient are kind of broad. So the inability to fulfill the role as a member of the cross-country team. This now has a patient fearing that she may lose her scholarship or not be able to compete in races and letting her teammates down. You also may see lower SF12 or SF36 scores, which is a measure of health-related quality of life, including limitations for physical and mental health. And then societal limitations for this patient may be inability to walk her dog for long duration. So the societal limitations are not always sport-specific, but may have an impact on the other aspects of her life. Finally, the disablement model looks at the environment itself. For this patient, it may be difficulty at her job at Best Buy where she has to stand and walk around for 5 to 6 hours per shift outside of cross country. And also have maybe a feeling of being left out from the team due to decreased training sessions with her teammates. Both of these are dimensions of the health-related quality of life that we will answer from the societal portion of the disablement model, in which societal and environmental considerations are seemingly overlapped. So now we'll look into how this actually impacts the patient now that we have a condition along the disablement model. The first are modifiable risk factors. Rather than using intrinsic and extrinsic factors, I've decided to use modifiable and non-modifiable. Using the Cameron article from the Journal of Athletic Training, they've split these into some subcategories, including environment and anatomical and lifestyle choices. For modifiable, we have things such as surface, footwear, coaching, volume, and intensity. These are things that we can modify based on the what is happening in that per that person. So the surface, there's literature to support that a risk factor for MTSS is a change in surface over the training sessions. In addition, the footwear that the person is wearing, the coaching style and volume and intensity. With the coaching style and volume and intensity, we need to understand where the pain begins to start for the patient and how the coach is instructing the person to run through the pain, or if they're listening to the person and the patient as they demonstrate that the pain has started in their lower leg. In addition, anatomically, we see an increased body mass index as a modifiable risk factor. Decreasing the body mass index for individuals includes things like diet, nutrition, and discussing how the health of that person impacts their overall health-related quality of life. Finally, lifestyle choices are supported in the literature as well. Smoking habits and stamina are two things that are identified as modifiable risk factors for people that have MTSS. In our collegiate population, this may not be something that we have to modify, and for our patient, that may not be the case, as she is a cross-country runner, and a smoker as a cross-country runner would have other limitations in terms of lung capacity and expiration. So it may not be something you see, but something to keep in mind for the general public. Next are the non-modifiable risk factors. Anatomically, this includes a navicular drop greater than 10 centimeters, greater hip external range of motion, and greater ankle plantar flexion range of motion. This is supported through a systematic review and meta-analysis and evidence-based review on MTSS. These three anatomical risk factors are from a list of 100 risk factors that are supported in saying that these are things that are present for patients with MTSS from epidemiological studies. A navicular drop greater than 10 centimeters cannot be changed anatomically without the use of orthotics. In addition, greater hip external range of motion and greater ankle plantar flexion range of motion are non-modifiable risk factors that we cannot change the range of motion of that joint except through limitations of external forces. Finally, hormonal cycles such as menstruation and failed bone healing are things to consider. The calcium levels of the individual and the menstrual cycle of where that person is at are things to consider when they're having this. Finally, previous history and sex or gender, which females are more prevalent for MTSS, are things to keep in mind. As we look at injury prevention, generally we want to have diet, nutrition, monitoring loads and training through coaching education, and lower extremity strengthening may be things to consider. Specifically, eccentric exercises for the tibialis anterior, orthotic use for navicular drop, progressive activity programs for increased BMI, and manual therapy for the hip and pelvis musculature are specific exercises for injury prevention that have been outlined in the literature. Overall, health-related quality of life for collegiate athletes, as has been documented in the literature in the Journal of Athletic Training, has a physical functioning limitations due to pain, social functioning, and physical composite scores. As we take the patient across the continuum of the Disablement model, we are able to understand how the health-related quality of life, the constructs of the SF12 and 36, make up the issues that we see on the Disablement model. In addition, while we have sport as a means of physical activity, we have to also understand that an article from Dr. Simon in the American Journal of Sports Medicine says that Division I athletics results in injuries that may make that person have a lower health-related quality of life. So working with this population is something to consider as well. Finally, the clinical integration of this to improve, mitigate, or eliminate. To improve the health-related quality of life for MTSS patients is through patient-centered prevention and intervention. To mitigate the risk, we have to use risk factors that have been identified in the literature through screening and education for the coaches. Finally, the elimination of MTSS cannot occur at this time. Due to the modifiable and non-modifiable risk factors, the issue may still be present depending on when the event to occur, similar to how the MUSI model has been developed.